Too much of a good thing, the water intoxication paradox. A truth universally proclaimed. Drink more water, stay safe, can turn lethal. An elite athlete followed every rule, and that is why she nearly died. It begins with a summer day, a half marathon, heat. The kind of race where everyone whispers the same advice: hydrate, hydrate, hydrate. But what happens when hydration becomes poison? A 22-year-old woman, collegiate-level distance runner, excellent prior health. The kind of athlete whose body seemed built for endurance. On race day, her body sent signals: confusion, disorientation, a severe headache. Not the burning dehydration kind, but a deep, expanding pressure behind her eyes. Nausea, vomiting, muscle cramps seizing her legs. Ataxia, that is, loss of coordination, the inability to command her limbs to move smoothly. And then something darker, generalized seizures, her entire body convulsing. The diagnosis would reveal something most people never suspect: acute symptomatic hyponatremia. Hyponatremia, hypo meaning low, natremia meaning sodium in the blood. Her serum sodium had collapsed to 109 milliequivalents per liter. Normal is 135 to 145. She was dangerously, critically low. But the question was why? Mile 11 of a race, 3 hours of continuous exertion. What had broken inside her? The timeline tells the story. Mile 11. That is when confusion began. A creeping mental fog, not what she expected. Fatigue, yes, but this was different. A dissociation, a sense that her own thoughts were not quite hers anymore. The headache deepened. Nausea rolled through her. She vomited. Her legs cramped violently, muscles locked and spasming. She could not coordinate her movements. Walking became a drunken stagger. The ataxia, the loss of coordination, was getting worse. By mile 13, by the finish line, her body had reached its limit. Generalized seizures, muscles firing chaotically, consciousness fragmenting. She was no longer aware of the race finishing, of the volunteers around her, of the danger she was in. Altered mental status deepening toward coma. Her body was failing, and no one watching understood why. Paramedics recognized the medical emergency. They loaded her into an ambulance, still seizing. In the emergency department, she was actively convulsing. The team moved fast. 3% hypertonic saline, a concentrated salt solution, was administered intravenously, 2 milliliters per kilogram of body weight, pushed over 5 minutes. This is the first-line treatment for symptomatic hyponatremia, and it worked immediately. The seizures stopped. The convulsions ceased. Relief flooded through everyone in the room. But stat laboratory results arrived moments later. Serum sodium measured at 109 milliequivalents per liter. Critical. Still critically low, despite the saline bolus. This was not going to be a simple stabilization followed by discharge. The patient was transferred directly to the intensive care unit. Cardiac monitors placed, continuous telemetry. The real crisis was just beginning. Sodium correction would take hours, careful, meticulous hours, because correcting sodium too quickly carries its own deadly risk. The goal was 10 to 12 milliequivalents per liter increase over the first 24 hours, no faster. But before the emergency, before the ambulance, before the seizures, there was an ordinary morning. She had trained for months, summer heat, distance work, the build-up to her goal race, and she had internalized the universal message every runner hears: drink more water, more is safer. Thirst is unreliable. So during those 3 hours of racing in heat, she drank 4 to 5 liters of plain water. Plain water. No electrolytes, no sodium, just water, hour after hour, trusting that conventional wisdom would protect her. She believed that advice because it is everywhere. It is what coaches say, what race organizers recommend, what the internet repeats. Drink more, always more. It is the consensus, the safe choice, the evidence-based guidance for avoiding heat illness and dehydration. She followed every rule to stay safe. That is why she nearly died. But what happens inside the body when water floods the bloodstream without sodium? What is the physiologic limit? Why does the brain swell? And how can a treatment meant to save you, more fluids, actually trigger a cascade toward organ failure. To understand the science of osmosis, of electrolyte balance, of the brain's razor-thin margin of safety, subscribe. The mechanism, the history, and how a single death in 2002 changed what we know about endurance sport forever. So how do we know it was hyponatremia and not something else? 3 candidates emerged from the clinical picture. Heat stroke. The race was hot. She had altered mental status and seizures. Heat stroke causes those things. But heat stroke requires a core temperature above 40 degrees Celsius. Her temperature was normal at 37.2. Heat stroke is anhydrotic. The body stops sweating dangerously. She was sweating profusely. And her urine osmolarity was elevated, which means her kidneys were desperately trying to excrete free water, a signature sign of overhydration, not heat illness. Heat stroke was ruled out. Hypoglycemia. Low blood sugar can cause altered mental status and seizures during long exertion, but her serum glucose was 118 milligrams per deciliter, normal. Hypoglycemia hits suddenly. One moment alert, the next moment confused. Her symptoms developed gradually over an hour, and the ongoing profuse sweating was inconsistent with hypoglycemia recovery. Hypoglycemia was ruled out. Meningitis. Encephalitis. Infections of the brain and its membranes. Those present with headache, altered mental status, and seizures. But she had no fever. Her temperature was 36.8 degrees Celsius. No neck stiffness. Her cerebrospinal fluid was normal. The timeline did not fit infection, which develops over days or weeks. Meningitis was ruled out. One principle solved the puzzle. The timeline was the diagnosis. 4 to 5 liters of plain water, 3 hours. Acute sodium dilution. Water shifting into brain cells. Cerebral edema developing over minutes. This pattern, gradual worsening over hours, then acute crisis, matches hyponatremia perfectly. Not infection, not metabolic collapse. Osmotic disaster. The story of how we learned this is a story of tragedy and discovery. Hyponatremia itself was first recognized as dangerous in the 1950s and 60s, in psychiatric patients taking medications that cause sodium loss, and in hospitalized patients receiving hypotonic intravenous fluids. But exercise-associated hyponatremia, the specific problem of endurance athletes, was not formally described until the late 1980s. A South African exercise physiologist named Dr. Timothy Noakes at the University of Cape Town began publishing case reports of marathon runners collapsing with seizures, confusion, and critically low sodium despite drinking water. In 1989, Noakes published his seminal mechanism paper in the International Journal of Sports Medicine, explaining how osmotic shifts caused water to flood into brain cells. Throughout the 1990s, neuroscientists at the National Institutes of Health and other research centers characterized the precise mechanism of cerebral edema and intracranial pressure rises. But the findings were slow to change practice. The conventional wisdom, drink more, was too entrenched. Race organizers, coaches, water stations, the entire infrastructure of endurance sport, all transmitted the same message: more fluids. The turning point came in 2002. A collegiate runner died at Northwestern University from exercise-associated hyponatremia during a football practice. That death sparked national attention. Athletic organizations could no longer ignore the evidence. In 2007, the American College of Sports Medicine and USA Track and Field convened experts and revised their official hydration guidelines. They overturned decades of drink more messaging. The message changed to drink to thirst, use electrolyte-containing fluids for exercise lasting longer than 60 minutes, and never exceed 500 to 750 milliliters per hour. A century of conventional wisdom collapsed in the face of research. It took a death to change what we were told about water. Back in the ICU, her sodium was being carefully corrected. The mechanism of her illness was unfolding in real time. Normal serum sodium is 135 to 145 milliequivalents per liter. The brain's volume is tightly regulated by osmolarity, that is, the concentration of dissolved particles in blood. When serum osmolarity drops acutely due to massive plain water intake, water follows that osmotic gradient. It shifts into brain cells by osmosis, the same force that pulls water across a semi-permeable membrane toward lower concentration. Endothelial cells swell first, then gray matter neurons. The brain expands against the rigid skull. Intracranial pressure rises. Cerebral edema compresses brain tissue, disrupts the delicate electrical signaling between neurons, lowers the seizure threshold. If severe enough, edema can compress the brainstem, the primitive core of the brain controlling breathing, causing respiratory depression and hypoxia. This is why seizures progressed. This is why coma threatened. This is why minutes mattered. The 3% hypertonic saline restored the osmotic gradient, drawing water out of swollen brain cells. Over the next 24 hours, her sodium climbed. 6 hours after the bolus, 118. 12 hours after admission, 124. By 24 hours, 134 milliequivalents per liter. Almost normal. She was awake, alert, moving purposefully. An MRI of her brain showed transient cerebral edema, swelling that had occurred but left no permanent damage. No scarring, no structural injury, just a swollen brain returning to normal size as osmotic balance was restored. 4 days later, she was discharged, neurologically intact, full recovery, no deficits, no seizures, no confusion. Just a young athlete who had learned, in the most terrifying way possible, what the body's true physiologic limits are. She became an advocate for proper sports hydration education and evidence-based training protocols. She speaks to collegiate runners. She teaches coaches. She knows that her suffering was not meaningless because it has made others safer. The question now becomes, what do we do with this knowledge? 4 rules learned in blood. First, for exercise lasting less than 60 minutes, plain water is adequate. Your body can handle the osmotic challenge. But for exercise lasting longer, half marathons, marathons, long training sessions, ultra-distance events, use electrolyte-containing sports drinks with sodium. Sodium maintains the osmotic gradient. Sodium prevents catastrophe. Second, the safe fluid intake guideline is 500 to 750 milliliters per hour. Not unlimited, not drink until you slosh. Your thirst mechanism evolved over millions of years to keep you safe. Listen to it. Honor it. Do not ignore it. Third, during any endurance effort lasting more than an hour, if you feel nauseous, dizzy, or confused, not just the expected fatigue of hard effort, but genuine confusion, stop drinking water immediately. Do not push through. Do not assume it is normal. These are warning signs of hyponatremia, not dehydration. Seek medical evaluation. Tell someone. Get help. These symptoms are the red line. Fourth, coaches, race organizers, athletic trainers, athletes themselves. You must know this. Exercise-associated hyponatremia is entirely preventable. It is not an unavoidable tragedy of sport. It is not a freak occurrence. Deaths and severe illness are caused by misinformation, by outdated drink more guidelines that persist despite being wrong. The sport itself is safe. The advice surrounding the sport had to change. And now it has. This paradox is resolved. The truth about water is not that we cannot have too much. It is that we can. And knowing where that limit lies is what